Okay, now we're moving to lupus nephritis, and we'll show where we've gone in the last 10, 12 years in terms of lupus nephritis. We'll do this through looking at a case again, we'll go through induction therapy, and we'll go through maintenance therapy. Here's a disease where this is all sort of worked out. So our patient is a 20-year-old African-American college student who has a 6-month history of a malar rash, arthralgias, and arthritis in her small hand joints, and recurrent pedal edema. She's evaluated by her private doctor and then sent to a rheumatologist, and she's found to have a high double-stranded anti-DNA antibody, low complement levels, and a urinalysis with 3+ proteinuria, 2+ hematuria. Her creatinine is 1.3. So, if the biopsy shows diffuse proliferative lupus nephritis or severe focal proliferative disease, think, what induction therapy would you use? Because there are options here, and we could actually take a vote in this room, and I bet you'd get people using several options here. But then what would you put her on for maintenance? And again, there are options to do it. How long would you leave maintenance therapy on? If she's doing well and she's been on induction therapy for 6 months and then she goes on maintenance for 6 months, a year, how long are you going to leave it on? What are you going to do when she wants to get pregnant? You know these questions are all going to come up. So we'll focus on diffuse proliferative disease, where most of the glomeruli are involved with proliferation and there's active immune deposits, etc. I will have 1 or 2 slides on the biopsy, because I want to tell you how I look at the biopsies of lupus nephritis. It's a good thing Helmut's gone, because he'll say, oh my God, no, you can't be doing that, but you'll see it. So for proliferative lupus nephritis, KDIGO guidelines are the same as the American College of Rheumatology. They're virtually identical, and for almost every major group, the induction therapy is pretty much the same. You either get mycophenolate and steroids for 6 months, or you get cyclophosphamide and steroids for 6 months. Now, the cyclophosphamide can be on the Euro-Lupus regimen, 500 milligrams every 2 weeks given for 3 months, or the older NIH regimen of 500 to a gram once a month for 6 months. Very few people are using the higher dose level because, again, the Euro-Lupus data works very well, and except I think the people at the NIH are probably still using it, but that's about it. Most people have gone over to Euro-Lupus, and there are still people who would use oral cyclophosphamide, but again, not many. But it's 6 months of induction therapy. If you get induced with MMF and you're doing well, you either go on mycophenolate or azathioprine maintenance. If you're induced with MMF and you're not improved, you get swung over to get cyclophosphamide by some regimen to try to induce you into remission. Makes sense. If you get cyclophosphamide for induction and you're improved, you go on maintenance with MMF or azathioprine. If you're not improved, then you swing over to the MMF arm. So we have 2 very good first-line therapies that either one can be used, and if you're failing one, you almost certainly go to the other. Now, these are a number of the studies that showed, let's see, I don't know if I can move that little thing. Let me X that out there. There we go. These are a number of the studies that showed how we got here. And it really, if you take it, you're talking about 10, 12 years at most that all the studies were done in. So I call this the Ginsler study. Ellen Ginsler was a rheumatologist who started this study. It's a multi-center trial of mycophenolate versus IV cyclophosphamide on the older NIH regimen in 140 patients. Now, the definition of complete remission was no activity and no proteinuria. This was an FDA-given definition, so it's really very restrictive. But still, to our surprise, the MMF was superior to cyclophosphamide. For partial remission, it was not different, but complete and partial, which was an endpoint, it was highly significantly better in the 140 patients. So this suggested that MMF was indeed a player. This was followed by the ALMS trial. The ALMS trial had a lot of advantages over the original Ginsler study. The original Ginsler study was only in the United States. The ALMS trial was multinational. A third of the patients were in the Far East, mostly China. A third of the patients were in the US. A third were South America and Europe. So again, a much broader distribution. much larger numbers, 370 patients versus 140, and the trial design was much better because the initial study had that after 3 months, if you weren't getting better, you could swing over to the other arm of therapy. Now you may say, well, why would they do that? The reason was most of the centers were rheumatology centers. They had never used mycophenolate before that first study, and they were afraid it wasn't going to work. They'll have their patient on a drug that doesn't work, and they can't use cyclophosphamide for 6 or 12 months. So we allowed them to do that, but again, it wasn't the perfect design. Here, all 370 patients get randomized and allocated either to mycophenolate for 6 months or IV cyclophosphamide, same dose of steroids with a taper. Then, at the end of 6 months, if you're a responder, you go into the maintenance phase of the study, which we'll talk about. So, in the ARMS trial, it turns out the mycophenolate was not superior to IV cyclophosphamide, but it was identical to it. It had exactly the same remission rate here, the same decrease in proteinuria, the same stabilization of the creatinine, the same remission of hematuria. So a lot of people said, even though that isn't superior, if you get equivalency in 2 studies or even superiority in one and equivalency in the other, and we feel it's a much more benign drug, I'd rather have my patients on mycophenolate than cyclophosphamide. Now again, I know John uses some cyclophosphamide for his ANCA patients. I try to avoid it. Cyclophosphamide is my least favorite drug. The only thing less favorable is a long course of high-dose steroids. I mean, they're both up there that I don't like to use them in I don't like to use them in anybody, let alone young people. So again, this was a win for the mycophenolate. Now, at the same time that mycophenolate came out and said, okay, we've got 2 studies that show that it works, that the Euro Lupus group was working in Europe trying to get a safer cyclophosphamide regimen, and they did. First study was a multi-center prospective trial of 90 lupus patients with proliferative lupus nephritis. They got monthly high-dose IV cyclophosphamide once a month, 0.5 to 1 gram per meter squared, just like the NIH was doing, or they got low-dose, that is 500 milligrams, not per meter squared, just 500 milligrams every 2 weeks for 3 months, and then they switched over to the much more benign azathioprine. The follow initially was 41 months. Subsequently, there's long-term follow. Without going through the short-term follow, which was equivalent, at 10 years, the regimens had exactly the same freedom from end-stage renal disease. Good long-term follow in these 90 patients. If you look at the creatinine at the end of 10 years, 1, same in the high-dose and the low-dose regimen. If you look at the proteinuria, 0.6, 0.5, identical. Now, a lot of patients needed some steroids, some ongoing glucocorticoids, because again, it's 10 years out, they might need a low dose, etc., and other immunosuppressions were used, but they weren't different. The biggest difference between these groups were the cumulative dose of IV cyclophosphamide in the high group was 9.5 grams. In the low group, it was 5.5. Now you can say, well, how did it get to be 9.5? Because people relapsed and they got treated again. And this is what happens with lupus. You get treated, then you relapse, you get treated, you get relapsed. And again, if you can get by with a lower dose of cyclophosphamide, that is huge. Because I can tell you, all you have to do is, this is young people, whether they're male or female, all you have to do is mention hair loss, and infertility. That's it. You'll never use cyclophosphamide again. Anyway, so that's our induction therapy, our 2 induction therapies. Now, what about maintenance therapy? So American College of Rheumatology and KDIGO agree. If you get induced with mycophenolate and you're improved, you go on to mycophenolate maintenance or azathioprine maintenance. If you get cyclophosphamide and you're improved, you go on to those same 2 maintenances. If you're not improved, of course, you get run to the other arm of therapy. So where did we get the mycophenolate and azathioprine maintenance? The first study that showed this was actually back in 2004. And this was a study by Gabe Contreras. It was a small study. There were only something like 20 patients in each arm. But what he did is he gave everybody 6 months of Cytoxan and steroids induction. And then, if people were doing well, he randomized them to continue get every third month cyclophosphamide or azathioprine or oral mycophenolate. Now, you may say, well, why did he give every third month cyclophosphamide? Well, if you're an older person, or never mind, not older, if you're a person with gray hair or no hair, you remember that's what the NIH did standardly. They gave every third month cyclophosphamide, and they gave it up to 4 years. So that was the regimen everybody was using. Except if you look at freedom from death or chronic renal failure, pretty hard endpoints, the cyclophosphamide group did the worst in maintenance compared to the oral agents, azathioprine and mycophenolate. If you look at freedom from relapse, here's the mycophenolate, here's the azathioprine. Again, they're both superior to continuing cyclophosphamide. So you're getting away from a toxic drug and you're getting better effects. And when you look at the side effects during the first year, 13 days of hospitalization in the cyclophosphamide group, only 1 day in the azathioprine and 1 day in the MMF group. Amenorrhea. If you keep using cyclophosphamide on young people, you're going to get a third that have permanent amenorrhea in every group. It's down to like 6-7%. And again, those are usually the older people in the group if you take the oral agents. Infections reduced, major infections not statistically reduced, but again, from 12 to 3 to 3. The oral agents were more effective, and at the same time, they were less toxic. Well, this virtually changed everybody over to using oral agents for maintenance. They just got away from the IV Cytoxan every 3 months. Everybody said, get an induction, and then switch to an oral agent. Now, we have 2 more maintenance trials, though, that add a little bit to that. One is the ALMS maintenance trial. As I showed you before, it was a 6-month induction study. But then, if you were doing well, and 220-something patients were doing well, you got re-randomized here to either mycophenolate, 1 gram twice a day, or azathioprine, 2 milligrams per kilogram, for the next 3 years. This 3-year maintenance is double-blind randomized. Now, it's easy to tell whether you're getting an IV drug or an oral drug for induction here. And a lot of studies, if you've done any studies, a lot of times if the patient is on one drug or the other. The MMF and azathioprine is pretty hard to tell which drug they're on. So this is a blinded, randomized trial. And, to my surprise, the MMF came out significantly superior in the final endpoints to azathioprine. That's in 227 patients followed for the 3 years. If you looked at treatment failures, 17% with the MMF, 30-something% with azathioprine. End-stage renal disease only with azathioprine. Renal flares higher with azathioprine, doubling creatinine higher with azathioprine, rescue medicines needed higher with azathioprine. Some broad FDA definition of doing badly higher with azathioprine. The azathioprine group was not as good as the mycophenolate in any of the endpoints. Because this is a large trial and you still had 227 patients in it, you could look at breakdown. So if you looked at overall, these are treatment failures, 17% versus 36% or 35% of the azathioprine. Whether you were white, black, Asian, or whatever is left behind, you did better on the mycophenolate. If you were in the US, Canada, Latin America, Asia, or Europe, you did better with the mycophenolate. And most important, if you started with 6 months of mycophenolate and got randomized to stay for 3 years on mycophenolate, you did better than if you started with cyclophosphamide. You did better than if you started with the induction with mycophenolate and got switched to azathioprine. So the MMF, going from MMF to MMF was better than going from MMF to azathioprine. If you started with cyclophosphamide and you got put on MMF, you had less treatment failures than if you got switched to azathioprine. So every single endpoint was positive, suggesting that the MMF was a very good maintenance drug. Now, at the same time, the Lupus group and Fred Husio's group in Europe was looking at maintenance therapy in their regimen. That is, they gave everybody 3 months of cyclophosphamide, that is every 500 every 2 weeks, the Lupus low-dose regimen. They then gave half the group azathioprine and half the group MMF. And they came out with a conclusion that there was no statistical difference between the two. So what's the difference between these studies? Well, one thing is they didn't do end-stage renal disease or doubling of the creatinine because it's a European population. They all do well. They're all Caucasian. They're all going to do well, as you can see from the results. They used the probability of not having a renal flare, a much softer endpoint. Secondly, they only had 90 patients in the study as opposed to 220. So the flare rate was 25% with azathioprine, 19% with mycophenolate. It's not statistically significant, but if it had been 220-something patients, it probably would have been statistically significant. So it could be a numbers thing. Or it could be just looking at that population, Caucasians do well, and therefore it probably doesn't make a difference in them. Now, just to support that, this is data from a Mexican series from University of Mexico, where they looked at MMF in green, induction and MMF maintenance, versus IV cyclophosphamide, induction in orange and blue, switched over to MMF and azathioprine. The two MMF maintenance groups, here you're looking at orange and green, did better than the two that got put on azathioprine. It's a minority group, again, you can say. If it was in the United States, they'd be a minority population. They're the majority in Mexico because they're Mexican. But nevertheless, it supports the idea that certain groups will benefit from mycophenolate over azathioprine. And here again, you can see the whole renal flares as well. So freedom from renal flares is better with mycophenolate. Now, that doesn't say that azathioprine is not a good drug, and it doesn't say you can't use it, and if your patient wants to get pregnant, or if your patient can't afford the mycophenolate, because even though they're both generic here, azathioprine is still much cheaper, you could use it. Certainly you could, and you get a very good take rate from it. But if you're dealing with a minority population, you might want to swing to mycophenolate, especially if it's not an issue of pregnancy or of being able to afford it. So that's our induction and maintenance regimen. Now, in doing a biopsy in somebody, if we know they have lupus nephritis, they have heavy proteinuria, they have red cells, should we do a biopsy, and how do we interpret this biopsy? So, as most of you know, we use the ISN-RPS classification, which has been around for a little while now, and actually we've had a couple of committee meetings about whether there should be a new classification, and everybody decided that we haven't learned this one yet. So trying to give you another classification that adds on blood vessels is just going to confuse people more. So you can see it has minimal mesangial lupus nephritis, mesangial proliferative, focal with active and active chronic and chronic, diffuse with active, active and chronic, membranous and advanced sclerosis, which is over 90% glomerulosclerosis. So how do I interpret a biopsy on one slide? This is my 6 points for interpreting the biopsy. Unlike John, they were not all the same thing again and again. There are 6 points. First of all, is the biopsy adequate? The more glomeruli you have, the better. But when you give the pathology to the pathologist, the renal pathologist, if you gave them the whole kidney, they'd ask for the other kidney. There's no way to give them enough glomeruli. But if you have less than 7, you're really making a guess. You could pick 7 good ones, or 7 in a scar that's by the capsule, and then, the others are all okay. So the more the better. The ISN classification, do not treat Class 1, Class 2, Class 5 membranous, you're going to treat a little differently, or Class 6, which is scarred, as active proliferative. The ones that you're treating vigorously are Class 3, the focal proliferatives, and the 4. And even then, only if there's an A. If it's A or AC, it's treatable. If it's C, it's all chronic. There's nothing to treat. You could have a 3C or a 4C. It's just all scarring. Yes, a lot of the glomeruli are scarred, but that doesn't mean you need vigorous therapy. For the membranous, vigorous therapy for 3+5 or 4+5. They have to have a proliferative component. The more chronicity, especially interstitial fibrosis, the lower the benefits. If you take glomerular sclerosis, the correlation with outcome is never as good as you'd like it to be. I mean, in any disease, interstitial fibrosis always correlates better with outcome. So if you have 50, 60% interstitial fibrosis on a good biopsy sample, 2 cores, that person's in big trouble already. If you have 70% glomeruli sclerotic, you still may be able to get a good remission in terms of this and get their function back. Are the deposits extensive? Now, the pathologists read the deposits by IF and EM. I don't put much stock in the extent of deposits. What type of deposits by IF? Yes. IgG, IgA, if it's full house staining, yes. But the location in terms of this is much better by EM. IF is much more sensitive, but it's somebody reading it in a dark room. They say it's 2+, 3+. EM, you have a picture in your hand. They give you an 8x10 photograph and they say, here are the deposits. Well, that's where the deposits are. So unless you've seen pictures of the IF, I mean, you can always be fooled by that. But extensive immune deposits, again, by EM suggests active disease. Fibrinoid necrosis of glomerular tufts and crescents are bad findings. That is a general rule for every kidney disease. The more crescents you have, the worse the disease. The more fibrinoid necrosis, that's a sign of vasculitic type involvement of small vessels. And the repeat biopsy can give you a lot of information. There's a famous, now deceased pathologist, Gary Hill, who used to say, if you can only do one biopsy on your patient, you should make it the second biopsy. Because the second biopsy gives you so much information. You know whether it's all resolved or it hasn't resolved over time. Anyway, that's 7 things you can look at on a biopsy. I guarantee you'll come out almost as good as if you look at everything and read some very long report. How long do you treat for? We have our 22-year-old female. How long are we going to treat her for? Well, we'll follow the guidelines. So the guidelines all are outdated because they're all several years old, and they all came out at the same time in 2012. There's EULAR, the ACR, KDIGO, the Dutch guidelines, the consensus from in juvenile SLE, and the Japanese guidelines. They all came out at the same time based on the exact same data, the ARMS trial and the Lupus Maintain trial. So they're based on the same data. So the EULAR data recommends 3 years of therapy. KDIGO recommends 1 year of therapy. The Spanish, even though they're part of EULAR, recommend 2 years after complete remission. That everybody at least agrees, don't just stop, gradually withdraw therapy. There's no advice beyond 3 years. You're on your own in terms of what you're going to do. And probably the ACR puts it best. To date, there are not adequate data to say how rapidly or how quick you should be tapering these drugs and how long they should be used. So again, at least you have guidelines to do this for several years, for 3 years in terms of the ARMS trial, and for 4 years in terms of Maintain. There's very good data that those patients are going to do well. Now, the type and duration, I'll just give you my own feelings, but again, they're based on the same. Somebody could take the same studies and come out with different conclusions. I favor MMF, especially in minority groups. However, I have no reluctance to use azathioprine if they can't cost it, if they're pregnant, if there are other factors that involve. I mean, you could think of things the other way. I mean, if somebody had bad gout and they needed allopurinol or febuxostat, then you wouldn't be using azathioprine. You'd have to use MMF. But again, I could use either of them interchangeably, especially in Caucasians. I favor 3 to 4 years of treatment for bad proliferative, bad focal proliferative or diffuse proliferative, except in certain circumstances. If they're doing great and they're older and they want to get pregnant and the clock's ticking in terms of that, fine. Then I can say, okay, you could either take azathioprine or we could try to taper you off altogether. If they're having side effects of therapy and they're constantly getting leukopenia or something and they've been in remission, you may only want to say 2 years of therapy, 2.5 years. Certainly at 3 years, I try to make an effort to taper them off. For membranous lupus, the important rule is if they're nephrotic, you can try a short course of therapy, 1 or 2 years, but don't blast them like you would a proliferative. They're going to do well most of the time, and most of the time that proteinuria will come down. And if it doesn't come down, I was already asked that question before, and somebody, asked me about what to do for a membranous lupus patients. You could use MMF, you could use rituximab, or you could use a calcineurin inhibitor. Calcineurin inhibitors are great to reduce proteinuria. Most of the membranous patients have heavy proteinuria, but a normal GFR. Their creatinine's okay, they're not serologically that active. Tacrolimus, because it's a female population, would probably be a very good choice. Okay, back to our 20-year-old college student here with lupus nephritis. Let's say she fails both induction therapies. She fails MMF and she's failed on IV cyclophosphamide. What therapy could you use? Or let's say she had a good response and she's on maintenance therapy. And she's on maintenance therapy and you taper it down and she relapses. What other therapies are available to you in 2017 to treat her? So for relapse or resistant patients, there's rituximab, there's belimumab, which has been listed in the United States, there's abatacept, there's anifrolumab, which is an anti-interferon alpha, there's ACTH, there's a new CNI, voclosporin, which is not FDA approved yet, so I'm not going to talk about it, and there's multi-targeted therapy. You have a lot of options available to you at this point. So let's go through some of these. What's the data and where are they? Now, before I do, I just want to point out something that should be obvious to everybody. I think I spent half my time with patients looking for stretch marks from steroids, half given by rheumatologists, half given by nephrologists, but the problem is, even though the reddishness of these stretch marks will go away, they're not going to go away entirely. This lady, the first thing she said when she came into the office, she said, "Dr. Appel, you got to have something else other than prednisone to treat me." She was the most cushion-eyed person I had seen. And this was a guy who was captain of his high school basketball and football team, and then developed a disease that required long-term steroids and got put on daily high-dose steroids long enough that he just didn't turn into anything very good. And again, part of this is not reversible. So again, you've got to watch your patients. High-dose steroids alone isn't that good. Cyclophosphamide has tons of side effects if you keep giving it. Again, you know all of those. This is just from the last of the NIH trials. Just look at 20 patients here, cyclophosphamide or cyclophosphamide plus steroids. Aside from hypertension here, aseptic necrosis here, premature menopause in over half of the patients here, major infections, zoster, these aren't great medicines unless you use them very carefully. Now, you do better than they did in those days. We all do. But still, if you can keep away from cyclophosphamide, prolonged therapy or long treatment courses, if you can keep away from high-dose steroids for a long period of time, your patient will love you. Okay, so what else can you do? Rituximab. Rituximab has been studied in 3 trials for lupus. 2 for lupus, 1 for lupus nephritis. This is the only lupus nephritis study. It's negative. It's a negative trial. In this study, and I have to say, I helped design it myself. Everybody got the same dose of steroids. Everybody got a full dose of mycophenolate. So they started off, trying to get between 2 and 3 grams a day, and then for maintenance, 2 grams a day. This group gets IV rituximab, 2 weeks later, IV rituximab, again, 6 months later, IV rituximab, IV rituximab. This group gets placebo, 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 IV. Double-blind, randomized trial. Perfectly designed study. It's probably one of the worst studies I've been involved in, because we designed it too well. And I'll show you why. One of the things was that Genentech, who makes rituximab, they said, we've done all the statistics, you need 140-something patients. And we said, but the ARMS trial needed 370 patients, and the Ginsler trial was only significant because they were using those rigid definitions. He said, no, we've got it all figured out. So what happened? If you look at the percentage with the renal response, it was 46. Actually, this is the number of patients. 46 out of 72 with placebo, 57 out of 72 with rituximab. That is not statistically significant. Now, the dose of MMF was about the same in both groups. The steroid dose was the same. The problem was that you can't interpret that. Is that rituximab was not effective, or was it effective and the number of patients was too small to show it? If you had 300 patients, you would have shown a statistically different effect between these drugs. So it could be a matter of numbers, or it could be if you have a full dose of mycophenolate and steroids, adding rituximab doesn't make that much difference. In any case, despite the fact that there is no controlled trial showing rituximab works, it's been used again and again in lupus nephritis. In fact, there was an editorial by Joan Merrill, a leading rheumatologist in the country, on this. Right after the last study came out, she wrote an editorial for their best journal, Arthritis and Rheumatism. It was called Rituximab, Wanted Dead or Alive, because no matter how many studies came out that said it wasn't working, everybody was still using it. And they used it because it seemed to work for salvage therapy. So one of the things that was done is that they used it in a steroid-sparing regimen. Now, this is data from the Imperial College. What they did is, since 2006, their regimen has been for any active lupus here, they give methylprednisolone only on the 2 days that you get your rituximab. You get your rituximab, you get a big dose of methylprednisolone with it. I usually give 100 milligrams to avoid reactions due to the, it's a chimeric half mouse, half human molecule. But they give 500. Then 2 weeks later, they give another 500 of Solumedrol with the rituximab. And in between, they use MMF for the next 6 months. They don't use any steroids at all. Totally steroid-free between, no oral steroids. So the data was published at 50 patients. There were abstracts that go out to 75 and 100, but here you can see complete and partial remissions in the first 50 patients, mostly complete remissions. There is a relapse rate here, again, but this relapse rate is out at 3 years you're talking about. It's 156 weeks here in terms of that. If you look at focal proliferative, diffuse proliferative, or membranous, they all respond. So again, obviously you seem like you've had a pretty good result. Here's the urine protein creatinine ratio coming down. Here's the serum albumin coming up. Here's the serum creatinine. You can't really see it, but it does come statistically down here. So again, these patients did okay. Now, that led to a number of trials. The Rituxaloop trial is a trial of, again, methylprednisolone only when you get rituximab, plus MMF, you get no oral steroids here, versus methylprednisolone, MMF, and regular steroids, the ARMS type trial here. 252 patients. I'm not going to go through more details of it because it's in the UK and it's on hold. It is unclear whether the UK is going to continue with the study. Now, there are a couple of reasons that I've heard: low recruitment, that their funding body doesn't want to continue funding another study here, and people are using it anyway, so why bother to do the study is what they're saying. But that's not the investigators. I mean, Liz Lightstone wants to do the study. Nevertheless, there are other studies looking at similar things. Obinutuzumab is in its phase 2 trial already. This is humanized. It's humanized rituximab against CD19, CD20 B cells. So again, you don't have to worry about first dose reactions and a big dose of Solumedrol. We'll see where that does in lupus nephritis. But again, that is being studied actively at the current time. But anti-B cell therapy is definitely there. Now, speaking of anti-B cell therapy, belimumab is a monoclonal antibody that works against BAFF or BLyS, the B cell lymphocyte stimulator or B cell activating factor, the same thing, but it activates B cells and leads to their proliferation. It's FDA approved for lupus, not for lupus nephritis. So what led to the approval of belimumab in the United States for lupus? They used a systemic lupus responder index, which included renal function, creatinine, things like that, but anti-DNA antibody, complement, arthritis, all these different things were thrown into an index. And you can see this is placebo, this is low dose belimumab, this is high dose. And there are significant improvements in the responder index. And the FDA approved it based on that. Now, the responder index is a much weaker thing than having just renal function. If you had to get proteinuria down and creatinine down and GFR up, those are very hard numbers. I always say everything is approved for rheumatoid arthritis. Nothing is approved for lupus nephritis. Why is that? In rheumatoid arthritis, if you get the patient to walk across the room faster, the FDA says, fine, your drug is approved. If I get my patients to walk faster, their creatinine is still the same thing as it was on the other side of the room. And the FDA says your drug is not approved. But the responder index is something they will approve, and this is being used now for other studies. So I think many more drugs are going to come out based on this. In any case, in those studies, there were something like about 250 patients who had over a gram of proteinuria. They weren't considered lupus nephritis. They were mostly just lupus, but still, this is remission. Placebo, low dose, high dose. This is people who had at least a gram of proteinuria. This is time to remission. Placebo, low dose, and high dose. Suggestive enough that there is right now a 464 patient study, the Bliss Lupus Nephritis study. It is fully enrolled already. There's another one, the Calibrate ITN. But again, these are studies that will be using belimumab for lupus nephritis. So presumably, and it's pretty easy to get patients into the study because it's an FDA-approved drug already for lupus. Abatacept is a co-stimulatory blocker. So, abatacept works between CD28 on T cells and B7-1 on B cells, blocking their co-stimulation. Now, without spending a lot of time on this, abatacept has not worked in any of the trials of lupus nephritis, none of them. So therefore, it's not going to be FDA approved. So why do I show it to you? Very important point in one of the studies. If you look at the ACCESS trial study, they used the Euro-Lupus regimen of low-dose cyclophosphamide, 500 milligrams every 2 weeks for just 3 months, and then switched to azathioprine. They gave everybody steroids. That was their background therapy. Half the group got abatacept, half the group got placebo. If you look, there was no difference. In fact, the placebo group, if anything, looked like it was doing better. The important thing about this study is they did it in both African Americans and others, being whites and other people. So the important issue is blacks did just as well with abatacept background as the whites did in terms of percentage. That's the first study that you're saying here that using the Euro-Lupus background therapy of cyclophosphamide at a low dose works in a minority group. So abatacept does not improve the outcome, but low-dose Euro-Lupus cyclophosphamide worked very well in a diverse North American population, which included African Americans. Now, you may say, well, look, it's still small numbers, but again, if you wanted to use cyclophosphamide on the Euro-Lupus regimen in somebody who was black, and you say, well, all the studies were in Europe because it's Euro-Lupus, it's all in Holland and Germany and Belgium, you say, no, there is data in blacks in America as well. One of the players that I think will be important is anifrolumab. This is an anti-interferon alpha receptor. So it's a monoclonal antibody that binds to the interferon receptor here, and it's been used in severe lupus nephritis. We know that the interferon system is turned on in active lupus, and it's all mediated through the type 1 alpha receptors here. And even though some initial studies failed with blockers of it, the initial one here in 305 patients was strongly positive. I mean, strongly positive. It's already been published. And again, they're already going on to the next study. So the next study, if it's positive anywhere near the same effect, it will be a drug that is approved for lupus. If it's approved for lupus, you can use it for lupus nephritis. So it'll be one of those things, again, that's an FDA-approved drug that you can use here. So we have a bunch of things coming out. We also have multi-targeted therapy. Multi-targeted therapy is a regimen that was devised in China They first looked for their patients who had both class 4 and 5, diffuse proliferative on top of a membranous background. And in China, that group did terribly in all their studies. So what they did is they said, let's use a regimen of MMF, TAC, and prednisone, and we'll compare it to IV cyclophosphamide and prednisone. And here you can see the probability of response was much higher in the multi-targeted therapy group. Now, one of the things is, this is published in the Annals of Internal Medicine. Now you may say, well, why isn't it in the Lancet or the New England Journal of Medicine? You're talking about 360 patients here who are followed over, a period of 6 months, and they've got a major difference. Well, part of the problem was that response included reduction of proteinuria. One arm has TAC in it. If you have tacrolimus or cyclosporin in one arm, you're always going to reduce proteinuria more in that arm because they're anti-proteinuric. They just lower the proteinuria. We don't know whether the multi-targeted therapy at 3 years had a better GFR or not. They might have had a worse GFR. We just don't know. We just know that for remissions, they looked better at this point. So that's the reason the paper kept getting rejected in other journals, but it did get into the Annals of Internal Medicine. They are following the group, and we will get a follow-up on this and find out exactly how these patients do long-term. If you have somebody who is responding, their creatinine's pretty good, their serology is better, but they still have persistent proteinuria, you can always add on. If they're male, I wouldn't mind adding on cyclosporin, but if they're female for hirsutism and thing, I'd add on a little bit of tacrolimus. Give them 1 milligram twice a day or 2 milligrams twice a day. That will almost certainly bring the proteinuria down, and if they're edematous and everything, it'll make it a lot easier. So where are we and what are we doing with our 20-year-old patient? Treatment in the future is still going to be divided into an induction and maintenance phase. The induction, most of the time now, is IV cyclophosphamide. Very few centers are using oral. Some do, but very few. Most use IV cyclophosphamide. Most use it on the Lupus regimen because, again, there's increasing data that you can get the same effect with less toxicity. The other choice, of course, is MMF, where you don't have to worry about fertility or hair loss at all. But there are other drugs that you could add on. We just talked about adding on a calcineurin inhibitor. ACTH has been studied. Proteasome inhibitors. Corticosteroid-free regimens with rituximab and anifrolumab. Any of these may be added on in the next 4 or 5 years here. The maintenance therapy is going to be mycophenolate or azathioprine, or maybe rituximab or newer agents will be added on here. It's clear we're going to be using combinations of immunosuppressives, and you'll be able to look at your patient and say, this patient already had cyclophosphamide twice. They're 35 years old. I'm not giving them any more cyclophosphamide. I'd rather use MMF. Or this patient has bad crescenteric. There's not enough data with mycophenolate in terms of this that I'm going to use cyclophosphamide like I'd use in other rapidly progressive GNs. You can look at what they've had and think about this for the future. This is the way to do this because you have to individualize therapy now, and everything is being studied in large control randomized trials. You're going to have an answer for every one of these drugs. Hopefully the answer will be not only good enough for us, but good enough for the FDA as well. So I think we'll stop here with this.